Uh, Hi everyone, my name is Minas. I'm a postdoctoral fellow at the National Cancer Institute within the NIH. In this presentation today, I will provide an overview of our data where we identified blood markers that are predictive of lethal prostate cancer among African American men. So one of the major challenges in clinical oncology today is really differentiating men who have lethal prostate cancer from those with a more slow-growing disease. So to address this unmet clinical need, we sought out to identify immuno-oncological protein signature that is predictive of prostate cancer mortality using the NCI Maryland prostate cancer case control study. So for this study, we measured 82 proteins from serum samples of 819 prostate cancer patients, of whom 394 were African American versus the 425 were European American. So the blood that was used to measure these proteins were collected within a median of 5 months since disease diagnosis. And these men were followed up for a median of 9 years, during which 57 died of prostate cancer, while 222 died of all causes. So these are the 82 proteins that we measured. And some of them were involved in apoptosis, and while others in autophagy, chemotaxis, promotion of tumor immunity, suppression of tumor immunity, and vasculature. And these proteins were measured by Olings proteomics using a high throughput proprietary assay called proximal extension assay, where they use only 1 microliter of serum sample to measure 82 proteins simultaneously. So to identify a multi-analyte proteomic signature that is predictive of prostate cancer mortality, we evaluated 82 proteins along with 6 demographic clinical variables. And these variables are education, age, BMI, smoke, diabetes, and aspirin use. And of course, the outcome we're trying to predict here is prostate cancer-specific mortality. And the method we used for this study is a cross-validated regularized Cox regression model with elastic net mixture parameters from RIDGE, which is alpha equals to 0, to LASSO, which is alpha equals to 1. So interestingly, we did not identify a robust predictive signature of lethal prostate cancer for European American patients. We only identified a predictive signature for African American patients. So the performance of the predictors or the features was evaluated using 2 different but complementary selection criteria. One is feature frequency. This criteria captures the significance of how often a feature is chosen in an in-bag model versus the other criteria is feature coefficient. This captures the significance of the feature's weight in the prediction when chosen in the in-bag model. So alpha equals to 1, or LASSO is the top performing model. So for alpha equals to 1, we identified using the feature frequency selection criteria, TNFRSF9, pleiotropin, aspirin, and adenosine deaminase were the top predictors using the selection criteria. For using the feature coefficient selection criteria, the top predictors were pleiotropin, aspirin, and TNFRSF9. Of course, this is for alpha equals to 1 because that's the top performing model. And this is again for African American prostate cancer patients. So based on the 2 selection criteria, pleiotropin, TNFRSF9, and aspirin were the top predictors, where they predicted prostate cancer mortality in African American patients with an accuracy of 84%, about 84%. Pleiotropin and TNFRSF9 were positively associated with risk of mortality, while regular aspirin use was associated negatively with risk. So the 2 proteins alone predicted prostate cancer-specific mortality among African American patients with an accuracy of 78%. So if we look at a patient at the time of diagnosis that had low level of TNFRSF9 and low level of pleiotropin, we see that the majority of these patients are alive even after 15 years of follow-up. And we see similar prostate cancer mortality pattern for those that had low level of either of these proteins at the time of diagnosis. On the contrary, when we look at patients that had high level of both of these proteins at the time of diagnosis, we see that more than 50% of these patients die within 15 years' time since their diagnosis. And these patients, compared to the patients in others in the other three groups, were about six times more likely to die of prostate cancer than the patients in the other group. Again, this is for African American prostate cancer patients. So this finding really highlights that these blood levels of TNFRSF9 and pleiotropin can be used for risk stratification of patients at the time of diagnosis, particularly for African American patients. So because in the past we have reported that the immunome of Ghanaian and African American men were similar, we anticipate that these blood markers could be of use for African patients as well. So they may be useful to predict mortality of prostate cancer patients from Ghana or maybe other African countries as well. To conclude, a risk stratification strategy is particularly needed for prostate cancer patients with African ancestry. These patients disproportionately bear the prostate cancer burden. So such risk stratification strategy is needed, and we believe our work is a step in the right direction. And what we identified is that these two markers, pleiotropin and TNFRSF9 alone, were able to predict prostate cancer mortality or lethal prostate cancer among African American patients with an accuracy of 78%. So again, highlighting that this could be used as a risk stratification strategy for African American patients, but also possibly for African patients, because we see similarity in the blood-based immunome of Ghanaian and African American men in our previous work. So, of course, future work requires validation of this findings. A number of people to thank, particularly with study volunteers. The PI of the study was Stephen Amps and Julian Candia, who was a bioinformatician who's made significant contribution to this study. Thank you very much for your attention.